time for your lunch, and I know it's been a very interesting 1.5 days that you've already spent. I'm not sure how much more I can add to the richness of the discussions already. Let me congratulate the IPH and the ITM for something very meaningful, more so in our country where ideological discussions often outstrip evidence-based discussions. I'm extremely happy to find a large number of friends, activists, researchers, Dr. Sudarshan with the work that he's doing across various parts of the country, Dr. Jacob with the new ways of looking at health, hospitals, medical education from time to time in the Hindu, whole lot of new approaches. And I'm sure when our friend from ITM was making the point about there being a lot of churning, if there's one thing which we all seem to be noticing over the last some years now, there's a lot of discussion. There's a realization that perhaps we are not doing what we ought to do, that public health is neglected, that public systems are neglected, that there is a case for crafting credible public systems. I was debating whether to go through a presentation route or to simply make the points in a free-flowing manner. It just struck me that at times it's always a good idea to be a little more structured. So with your permission, I will run through a few slides with you on the subject that has been assigned to me. I'll only begin by saying that it's presented in all humility and with the realization that we have only taken the first few steps towards what ought to constitute public health, towards what ought to be rights of people, towards what ought to be credible public systems. And there is a whole long way to go, a very long way, but at least the confidence that the initial first steps are perhaps leading us towards reinventing systems. And I can assure you that a lot of the findings of the research that all of you have undertaken in various pockets of the country is all adding to the knowledge that should contribute to how public policy and public programs move, the direction that they take. Reinventing systems doesn't happen overnight, and especially when we talk about processes and communities coming into the mainstream, there is always a time frame, there is always a time period that it takes to really push certain ideas in the system. Our frustrations are very real. I can assure you that I have been as frustrated as many of you many a time traveling to the various corners of the country. But the only thing that keeps all of us moving on is at least, maybe something is changing. It may take a little while. So I think when we deal with public policy in a country of over 1 billion people living in 1 million places, patience is an attribute we all have to have, much as we must always be very self-critical about whatever we are doing, looking at ways of doing things better. But yes, it does take time. I don't need to spend even a minute on this slide with the audience which is here. The starting point has to be to understand what we are, what our issues and problems are, because again, health is not medicalized care. Health is about well-being. Health is about a whole lot of wider determinants which are required, if at all, the kind of quality of lives that we wish to guarantee to our citizens. It's not just the hospitals and medicalized care. Given a context of persistent poverty and undernutrition, post-91 we may have managed very high rates of economic growth. Unfortunately, while it has led to reduction in poverty based on most of the studies and numbers that are getting published, but what is also coming out is that increase continues to be modest. There's a whole lot of social development agenda which needs to be covered in the coming years at a much faster pace. That public expenditures are low is known to everybody here in the hall. India has one of the lowest public expenditures in health and one of the highest out-of-pocket expenditures, often made under distress and duress, often made because no other alternative or option is available. The case of regional disparities, I think India has always been a country where Scandinavia and sub-Saharan Africa appear to coexist. certain states reaching towards single-digit infant mortality, and certain districts still hovering at more than 3 digits. The large unregulated private sector, a lot of the discussions I was listening in the session before this, there was a lot of deliberation about how we need to access private care, but very rightly the chair was repeatedly raising the issue of regulation needed if at all the private sector has to be involved. Dr. Sunil Nandaraj raised it in his questions. We've been looking, as part of this committee that I work on now on universal health coverage, we've been looking at a large number of models. A very interesting paper which Dr. Abhay Shukla has circulated recently on regulation, where they have looked at Canada, Thailand and Brazil more closely. And for a large number of friends sitting in this room, the way, while private partnerships may be required, in the absence of regulation, in the absence of standard treatment protocols, in the absence of proper ethical practices well built into these agreements and arrangements, there are issues. I know in the days of neoliberalism, reforms has become a bad word, regulation has become a bad word. But regulation is still needed. Health is a sector which doesn't lend itself to market principles very easily. Health is a sector with huge information asymmetry. It cannot be left only to market principles. It needs the countervailing presence of a well-functioning public system, both for cost of care and quality of care. I'd just like to illustrate that based on some of the experiences we have in the states. The health scenario is also known. We have the multiple burden, infectious diseases, chronic diseases, communicable diseases, non-communicable diseases, emerging problems of geriatrics, emerging problems of palliative care in some parts of the country, child and maternal health still unattended in many other parts of the country. But again, underlying everything is the high, very high, unacceptably high figures for undernutrition. There are enough global studies and evidence now which says that if we continue not to address undernutrition directly, all children who have faced undernutrition in their 0 to 3 age group run the risk of a large number of chronic, neurological and other disorders in later age. There is an entire body of literature, the School of Public Health in Harvard, Dr. Barker, a whole lot of them who've done work on that. So we are really staring in India at a very large problem of healthcare, medicalized care in later age on account of our persistent undernutrition. Issues of water and sanitation, food security, public health challenges. I think while we do regret that chikungunya, dengue and others have struck so virulently in the last few years, the silver lining to it is that it has made us realize how vulnerable we are. Our Commonwealth Games almost got scrapped. The vulnerability to public health challenges, because we've not addressed them. And I think something which Dr. Jacob, who's sitting in the hall here, one remark of his in an article I always quote wherever I go, the West fought public health challenges with clean water and sanitation. We are trying to do it with antibiotics. We'll never succeed. Very simple statement, but something which any of us, when we travel westwards, the first point which strikes us is hygiene, sanitation, cleanliness, provision of water. A lot of the problems and challenges of health have to be seen in that larger frame. Otherwise, the recurrence of chikungunyas and dengues and malarias will continue on an unabated scale. I know that this slide may appear to some policy people, academics, administrators a little odd, but I'd only say that, I wear both hats. While I work in the civil service, I've had the opportunity to work with some very good academics, and one of them whom I revere a lot and from whom I learned a lot, Professor Jean Drèze. The most interesting thing I find about Professor Drèze is that he believes in seeing the field. The map is never the territory for him, And he also believes in a multidisciplinary approach. When we did the public report on basic education, he insisted that the core team that works on it, it had a teacher administrator, it had a civil servant, it had an academic, it had an economist. It had a whole lot of skills which ordinarily don't work together to examine how schools are doing. The other feature in which I find in most of his research that when he looks at areas where we don't do well, he makes it a point to look at a state or a region which has been doing well. When we did the probe report on education, we looked at Himachal Pradesh. The focus report looked at Tamil Nadu. A whole lot of studies look at not only what doesn't work, but also what works. Because unfortunately, a lot of the research in our country remains very judgmental in the sense that, many a time, the micro evidence, which I find very happily in this particular workshop and conference, that everybody is looking at a micro case and then commenting on it, which is where a lot of learning comes from. But a general statement that public systems don't work, it doesn't help anybody, unless to point out exactly what is it that is the failing. So the linkage between theory and practice, beginning from the problem. Without mincing words, I'd say that in our country, we've had a lot of experiments in health. The health systems project, which were funded by the World Bank, Karnataka has also been a beneficiary, many other states have been beneficiaries. But we all know in many other states, especially in Orissa, in West Bengal, what happened? Large number of buildings got constructed, large amount of equipments came, but when it came to the human resources, it was said the states will provide for it. Now, is that how we plan our human resources for health? Is that how we go for a large investment in the health sector? That large buildings, lots of equipment, many of them didn't even get opened up in Orissa because there was nobody to open it up. The point I'm making is, begin from the problem, do not impose a solution without looking at the problem. Similarly, a lot of the debate on, I was hearing this in the morning about user fees. Luckily, many of these things got introduced not because of local demand or local felt need, because somebody somewhere thought that this is the right thing to do. Somebody at one point of time said, higher education needs no subsidy. And suddenly all funding for higher education from the public exchequers started reducing in many of the developing countries, especially Africa. And we know the ill consequences of it today. Similarly is the case of the user fee. There is enough study now available, and I would say that now the stage is not that the jury is out, but the results are out. I don't think it has really been able to do what it aimed to do in any part of the country. Registration fees one can understand, but user fee contributing to better health of people, unfortunately, there is almost no evidence from any part of the world. We'll get into it again, but I think the exclusionary aspect of user fees came out very strongly in a large number of the African countries. I was sitting at a presentation recently made on the World Health Report, and a lot of the evidence I can share with you later in the day today. I think the last but one point on Samakhya, or the dialogue of equals, again in all humility in this room here, it is not, I'm not saying that the organizers have not done their homework, but then that's how we are. We will never find Ashas and Anganwadi workers and auxiliary nurse and midwives and staff nurses sitting in a deliberation like this. We have to move towards a dialogue of equals. A lot of the insights which come from the cutting edge frontline workers does make a difference. And unless and until we are open to it, and I think that is a process again which more and more that we've been trying to do it in a very limited way, but I think there have been presentations. There's one coming up today also on community monitoring. Thelma is here. A lot that we have learned is through the community monitoring processes in many states, that at each level, there is a need to be open, there is a need to be transparent, and there's a need to have a dialogue of equals. I think a whole lot of things have been attempted. Don't mistake me.